The next session on real life management of MASLD in the Indian context. It's a panel discussion. May I please invite the panelists, Dr. Manas Panigrahi, Dr. Tarana Gupta, Dr. Swapnil Dhampalwar, Dr. Naveen Bhagat, and Dr. Prajna Anirvan. I'll also invite the moderator for this session, Dr. Kaushal Madan.
Yeah, so good afternoon. Thanks to INASL for giving me this opportunity. And we are here to discuss a case regarding real life management, and we have our experts here who will be answering all the queries. So this is the case. You all heard the basic science and whatever is in store, the new medications which are in store over next 2 to 3 years, we'll be having those drugs with us. But what about what we have right now and how to manage these patients? So this is a patient, a 48-year-old gentleman, follow-up case of type 2 diabetes, referred to us for deranged AST/ALT, no history of alcohol intake, BMI of 31.2. These were the parameters: AST/ALT 107 and 91, good liver functional parameters. Ultrasound he was carrying, which showed grade 3 fatty liver, viral markers negative, ANA positive 1:160. And this was the lipid profile, diabetes pretty well controlled. So I'll start with the first panelist, Dr. Tarana. I think we did have a discussion about this in the previous talks. Do you even bother about quantification of fat in the liver? You just heard Dr. Sanyal tell you that why not start at the bottom of the pyramid. So I think we have forgotten about this. So do you bother about quantification of fat in the liver? Do patients come to you and talk to you about, now we have grade 2, now we have grade 3, and how do you manage that? Now, yeah.
Hello.
Yeah.
So here we have a patient of diabetes, who is having raised ALT levels, which is 91, more than 2 times upper limit of normal. And then the ultrasound is showing grade 3 fatty liver. And definitely we should be bothered about the quantification of fat and as well as the fibrosis in this patient. And in normal routine daily practice, we will go ahead with CAP in our patients, which is incorporated in FibroScan machines. And CAP will give us a value, and sir is showing that. And the two methods, one is CAP and the another one is MRI-PDFF. And CAP will be used most commonly because MRI is not widely available, and CAP is easily to assess, and then we can actually have CAP values based on which we can assess the degree of S1, S2, S3, and we can quantify the fat.
Right, but many patients do come to us, and you would also have experienced that if you repeat their FibroScan, they come with 2 to 3 FibroScan reports, and the CAP values vary very widely. Somehow the reliability on CAP is lower than the reliability on the LSM values. Is that your experience also?
Yes, sir. Of course, it is actually the studies, the literature shows that the differentiation of S0 and S1 is very good with CAP. The ORAC values are much better. But once we go for S2 and S3 values, where the values are ranging between 260 and 280 for S2 and S3 is beyond 280, for that actually the values may be variable when we take these readings over different time spans and so on. So that is not very good differentiating S2 and S3, but definitely less fat S0 and S1 we can differentiate with CAP.
Right. So it does give us a semi-quantitative estimate, but we have to be very careful because the reliability of the CAP value in the FibroScan is slightly lower than the LSM values. And if we really want to monitor how the fat is behaving in the liver, whether it's increasing or decreasing, I think the gold standard is MRI-PDFF, and that has been demonstrated by a number of studies. For example, this one, which shows that it is not only easy to discriminate between all grades of steatosis, but also during follow-up when it's good even in discriminating whether the fat has reduced or not, or it has increased. Especially what we have learned about targeting fat alone when we start at the base of the pyramid. And this was a study which compared MRI PDFF with FibroScan cap, and obviously its performance was much better at all grades of fat. And the discrimination of the S1, S2, S3 was also significantly better than cap. So if we do want to follow how much fat is there, how much of it is disappearing or increasing, I think we need to have a more precise tool, and MRI PDFF scores over cap for that. But yes, I agree with you. The problem is with the availability and cost. So we move forward. So this was the FibroScan report, a cap of 289, LSM of 13.6. Liver biopsy, he was carrying a report of a liver biopsy with him, which we got reviewed at our center, which showed a distorted architecture and NAS score of 6/8 and F3 fibrosis. So this was the final diagnosis, because it looked like the LSM values was 13.6. We made a diagnosis of MASLD related CACLD, and thankfully before coming to us, he had already lost 10 kg weight. But I think that was not enough. His BMI was 31. We needed him to lose another 8 to 10 kgs. So that brings us to Dr. Pragna. I hope I have pronounced your name correctly. Dr. SP Singh will be angry with me if I don't do that. So how do you prescribe lifestyle intervention in such patients? I'm asking you because you've recently published a study on that. Do you in your prescription for this write about calorie intake or exercise prescription as well? Or you just educate them that this is to be done and then you forget? And how do you ensure compliance?
First of all, invariably I advise lifestyle intervention. I go to the extent of writing it, mentioning it clearly on the prescription. The second point is, what do I write? I write two things: walk 5 kilometers per day, reduce dietary intake by 50%. Obviously, there are a lot of areas here, problems are there, lot of calorie restriction, this and that, this diet, all these things. But the patient that I see, the setting I work in, the semi-rural, semi-urban setting where these things really confuse the patient. So I realized that my patient's diet is a heavily carb-based diet. So when I ask for 50% reduction in dietary intake and 5 kilometer daily walk, the results are there for everyone to see. We recently published our cohort of the data in our cohort of patients where we found good results to the extent of reduction of fibrosis. Compliance is a difficult task, but what we have found is that we spend time with patients, more of 5 to 10 minutes, give them short-term goals, maybe 2 kg of weight loss per month, educate them about the non-liver events. And non-liver events doesn't mean only heart and all. I ask them about osteoarthritis, about dyspepsia, constipation, that going to lose weight is going to help in all these things. And that works to a great extent. I can say that in our study, 72% of the patients had a good compliance of 1 year. So that is how we go about it.
So I think a question from the house, and I see Dr. Rakesh Agrawal there.
Is 50% reduction in diet really possible for most people? And if you are saying the target is 2 kg per month, I need to reduce my intake only by about 500 calories a day. To me, if I tell my patient that you reduce it to half, I can be pretty certain that the person says that I'm talking through my hat.
Right. So that was my next question.
545 of our patients did that, and they really believed us, and the results are there for everyone to see.
Right. I think, but there was a lot of issue about this 50% reduction in dietary intake in terms of calories, proteins, and minerals and trace elements. Right.
I think when we are in the process of publishing, there was a question, but this is a follow-up of 5 years. I don't know if these patients, obviously there's a limitation of our study, but there were no major adverse events in this.
Right. So this study did show that non-invasively, at least if the patient followed this protocol, they were able to achieve significant weight loss and a reduction in their shear wave elastography, and 40% patient did have one-stage reduction in their LSM. I'll just come to you. So this was the largest lifestyle intervention study in which they had done paired biopsies, and like Dr. Agarwal said, reducing calories from 500 to 750 at least to begin with may be sufficient, with saturated content, fat content to less than 10%, and at least 200 minutes of walking per week. And this is what it resulted in. And you are well aware of this pyramid, as the weight loss increases, so does the histological improvement, including fibrosis at least 10% weight loss. But unfortunately, only 30% are able to achieve at least 7% weight loss. So that is why we need to do something more than lifestyle intervention, or be very aggressive about lifestyle intervention, like Dr. Anirvan said. Yeah.
Instead of reducing just the calories, why not change the contents? Why don't ask them to stop the fructose? Because that will be a better and easier parameter rather than just asking them to reduce the calories. That is,
Right.
I think, not a, because I've been using the lifestyle clinic, running it since last 6 years. No patient is going to reduce the calories, and who is going to count the calories? You need to have special apps for counting the calories. It's not a practical suggestion, which I've stopped giving since last 3-4 years. Just ask them to implement. First thing, easiest is stop eating in between the meals, and second is stopping the fructose. So that will be much easier and the best lifestyle intervention to be offered. Reducing the calories of a patient is, unless he's super committed like me, who has to enter his daily calorie intake, no one is going to follow that.
Right, but what happens in real life if a patient is diabetic and you tell them to reduce sugar, they'll tell you that, Doctor Sahab, I am already not consuming sugar, or already I am consuming very little sugar. So unless you calculate their calories, it's very difficult. Fructose is, yes, which can be acted upon immediately. You know the sources of fructose and you can stop that. Especially vegetarians, they'll tell you they take a lot of fruits. They already say, Doctor Sahab, I consume a lot of fruit and vegetable. I thought my diet is healthy. But if you ask, they'll be taking half a kg of fruits every day, and that adds to fructose.
Dr. Madan, can I just here?
Yeah.
My patients have only 3 square meals a day: breakfast, lunch, and dinner. They do not eat in between. They have extremely large quantity of rice which they consume. And when I ask them reduce their diet by 50%, I find the results, and that is what we have published. So no matter, I don't want to complicate things by giving a lot of advice to patients, calories, proteins, this and that, because at the end of the day, they are not going to understand anything. They come from that setting. So when I ask dietary reduction, it ultimately translates into carbohydrate reduction.
I'm glad this is generating a lot of discussion, but I think we'll have to run through this and we'll have a discussion subsequently. Otherwise, the panelists will not get a chance. So I think the next question, we've already talked about the limitations of lifestyle intervention. Dr. Naveen, so when you have to start pharmacotherapy, do you start them in all patients? I think that's a simple question. If not, how do you select? If yes, how do you select?
Lifestyle interventions in all patients, but for selecting pharmacotherapy,
I think you'll have to keep the mic closer.
Sir, for pharmacotherapy, I would suggest, sir, significant fibrosis, at least LSM above 8 and above, because that will lead to significant liver-related outcomes. So in those patients, I will start pharmacotherapy. In all the rest of the patient, I will ask for lifestyle interventions.
Right. So moving up the pyramid which Dr. Sanyal presented, at-risk patients of MASH who have F2 fibrosis or beyond are the ones who are more likely to have liver-related events like decompensation and HCC. And following this protocol of detecting advanced fibrosis in the primary setting and then moving on to a fibroscan, this particular study looked at the outcomes. So more than 12,000 patients, the primary risk assessment was done by using FIF4 in the intermediate group. Then they subjected them to fibroscan, less than 8 low risk, 8 to 12 intermediate risk, and more than 12 high risk. And by following these patients up over time, the 5-year cumulative incidence of liver-related events was directly proportional to this risk stratification. So high-risk patients are the ones who are likely to progress and therefore should be targeted with pharmacotherapy. So coming to pharmacotherapy, the ones which are available in India, since we are talking about a real life case in India, how do you decide, Dr. Swapnil, which drug for which patient? Do you follow any algorithmic approach? Because we have a number of drugs now which target various factors in MASLD like fat, inflammation, and fibrosis.
Yeah, so I think it depends upon what metabolic risk factors and which metabolic risk factors the patient has and what we are targeting. Are we targeting fibrosis or are we targeting the weight? So if the patient, in the given context, the patient has an LSM of 13 with a BMI of 31, so I think we might choose from GLP-1 versus resmetirom.
Right. So I think Dr. Sanal again pointed out the effects of vitamin E. We since it's a very cheap drug and we still do not have to give it up. We are not in that stage that we can give up vitamin E just as yet, just because we have newer drugs with us. It is the only drug which is possibly has shown, although in a retrospective study, effect on clinical outcomes like the transplant-free survival, both in diabetic and non-diabetic patients with NASH, was significantly lower with long-term vitamin E use of at least a median of 5.6 years, and it also reduced all-cause mortality. We also already know about saroglitazar and its effect on significant effect on reduction of liver fat and as well as the ALT or inflammation, and some effect on NITs showing that there is some improvement in liver stiffness values, which may actually represent inflammation to begin with rather than fibrosis. Semaglutide and other GLP-1 RAs have a significant effect on mean weight change. In addition to this particular trial showed that had a significant effect on fibrosis for the first time. The previous two studies with semaglutide in MASH as well as in cirrhosis did not show this result. This was the first time it was shown that semaglutide did have an effect on liver fibrosis reduction. And now we have resmetirom, which also has shown improvement in liver fibrosis as well as metabolic profile in terms of reduction in LDL. So I think again coming back to the base of the pyramid, will targeting fat alone have favorable outcomes? I think since we are coming back full circle, trying to target fat in patients who do not have an indication of other kinds of pharmacotherapy, will targeting fat alone have favorable outcomes? Dr. Manas.
So thank you for the question, sir. So basically in this MSLD or NFLD, fat is the driver. Fat is the initiating agent. Similarly in HBV, SCV, alcohol, we are targeting initiating event. So definitely you have to target the initiating event. You have to target the fat. Of course, fibrosis is the most important predictor of the liver-related event. But if you target the fat, then it is not only the liver-related, the other non-hepatic, extra-hepatic events also we can decrease. So
Right.
of course you have to target fat.
And maybe the downstream effects of advanced inflammation and fibrosis will also come down, but yes, we need to have more data on that. Till now, we have this data which suggests that if you are able to show significant improvement in liver fat by a reduction of MRI PDFF by at least 30%, there is both reduction in liver inflammation as well as liver fibrosis. So the odds of having fibrosis regression with an MRI PDFF reduction of 30% were almost 6.4%, data derived from multiple randomized control trials. So it has an effect both on inflammation as well as fibrosis. Since we are so much after fibrosis, we want to look at an effect on fibrosis, and this does show that reducing fat has an impact on that. So coming to GLP-1 RAs, the most talked about drugs in all the MASH session these days. So Dr. Manas, how do you prescribe GLP-1 RAs to your patient in real life? Do you sell it as an anti-obesity drug or a drug for MASLD? And what about patients who are not obese but have MASH?
So till now, GLP-1 receptor agonist, in my experience, I have not practiced. But to me, if I'll see the literature and practicality, it is an anti-obesity drug which is working on MSLD. And do you prescribe anti-diabetic yourself? We have learned from Dr. Acharya sir, and he used to say that we should not refer all the patient to this endocrine fellow or medicine fellow. We should learn this and we have to prescribe this. So patient one-stop solution for this. We have to know all those things. Holistically, you have to approach the patient, not only treating liver part, other parts also, so that patient will get benefited.
Right.
And
so in my practice also, I think if you tell them that this will have a broader effect on multiple organ systems, possibly it is easier to prescribe. Otherwise, just prescribing for MASLD, an expensive drug like this in injectable form sometimes becomes difficult. And which anti-diabetic do you prefer in a patient of MASH? For example, this particular patient, if you have to change an anti-diabetic or switch, or you want to start an anti-diabetic, which one would you start? Question to you.
So this patient is in SGLT2 inhibitor, I think.
No, this patient was not on SGLT2 inhibitor.
So we can start with SGLT2, sir.
Right. So there are recent studies which suggest that SGLT2, starting with SGLT2, GLP-1 RAs are associated with lower hepatic decompensative effects as compared to starting thiazolidinediones, in which the decompensating events are higher, or especially when we talk about pioglitazone. So I think this is the final part of the discussion. This is to all panelists. For the purpose of stopping therapy, if you have to stop, give a finite therapy in patient with MASH, which parameter do you think is most important before you decide to stop? Is it ALT normalization, histological NASH, fibrosis regression by non-invasive test, or weight normalization? Anyone can answer, or all of you can answer.
There should be one ideal
We'll take 1 more minute.
Ideal target and practical target.
Both.
If you if you'll see ideal target, of course, fibrosis reduction and NASH resolution, and practicality, if you'll see ALT normalization at weight
Will you do a
normalization.
biopsy?
For
Will you do a biopsy to
for
decide this?
or decide this, I don't think in
I think no one will
BMX.
do a biopsy to decide this. So non-invasive assessment showing that fibrosis has regressed, and there are several studies which suggest that at least 20% reduction, and now somebody would talk about more than 30% reduction in LSM values, or an absolute value less than 10. If you achieve that, you are able to reduce the liver-related events, both HCC as well as liver decompensation. Many studies, I've just presented these two. This is what happened in our patient. This is here. Whatever we may have given to him, he reduced almost 20 kgs weight. We gave him on multiple drugs from 2019, 2005. LSM came down to 8. This is his weight, almost 20 kgs down, and this is his ALT. So do you think this patient is in remission? Dr. Tarana, I'm using this term. Do you think this patient is in remission of NASH?
So, sir, the parameters are like this: his ALT has normalized, his LSM has also reduced. It was beyond 16 or 15 at the start, and now it has come down to 8. So it fairly looks good, right? And
Right.
then he has also reduced around 20 kgs of body weight. But there is no such standard definition for MASH
Right.
remission. But yes, we can suggest to him that yes, you appear to be, in a remission phase.
Right. So Dr. Sanyal, we'll take your opinion on this. Can we start using this term remission of MASH just after we completed? So if a person has an ALT normalization, LSM regression to less than 10, and at least 20% reduction in body weight, is he in remission? Can we stop everything? And finally, since the LSM has come down, he was cirrhotic to begin with, and is stable around an LSM of 8, would you continue HCC surveillance or stop here? I'll just stop here with my take-home messages. While ultrasound is good for screening a population, MRI PDFF is the gold standard for quantification. Yes, monitoring of fat reduction does have clinical value, with more than 30% reduction in MRI PDFF having an impact on inflammation and fibrosis. But the driver of the disease still remains advanced fibrosis, and we have to target that also. Lifestyle measures in all patients who only have liver fat will require just lifestyle measures. Those who have inflammation, you can start with one of these drugs. Those who have advanced fibrosis, you can start with resmetirom or semaglutide. If diabetic, add or change to SGLT2 inhibitors. If obese, start with or add GLP-1 RAs. Remission of MASH is a new concept, is achievable. Definition may still be evolving. And again, like I said, we'll have your opinion now. But once a cirrhotic, surveillance of HCC needs to continue till more data accrues. Thank you so much. And sorry for exceeding the time. Dr. Sanyal, can we have your opinion on that?
I think the points you made are all very well taken. I think you have to be a little careful about the choice of the actual word, because people attach meanings to words which may not be intended. So whether it is it's a complete part, there's a lot of debate going on whether to call it remission or to call it complete responder, partial responder, non-responder, and how to draw those lines. So I think this is something to keep an eye on, but clearly the patient you described seems to have improved, right? I think we can all agree that if your liver stiffness goes from 15 to 8, your liver enzymes normalize, and your liver fat decreases, you've had more than 30% improvement in PDFF, that person is doing well.
Right. Thank you. Thanks to the panelists. I think we can close this session.
Thank you, sir.
Thank you.